Hello, and welcome to Tech and HSR. Today, we're going to talk about synthetic data and why there's this widespread confusion about what it is and how it should be treated in research oversight. Research compliance professionals are increasingly unsure how to treat it. Is it non-human subject research? Is it exempt? What are the actual risks? And what happens if we get that determination wrong? So this presentation is going to explain why synthetic data should not automatically be treated as what many call fake. Or harmless or exempt from IRB oversight. The goal is to help IRB members and research administrators make informed, risk-based decisions using existing federal rules and guidance. And to do that, we first need to understand, well, what is it? Why synthetic data is becoming so common and why assumptions about it are driving inconsistent decisions. So synthetic data is increasingly used in AI development and research. Many IRB teams assume that if data is labeled synthetic, then it might not involve human subjects and therefore not require regulatory oversight. That's a common misconception, which is that synthetic data is either like entirely fake or de-identified. That assumption is going to lead to compliance gaps, ethical blind spots, and inconsistent IRB determinations. And this topic matters because oversight decisions depend on how the data was created and how it is used, not simply what somebody decided to call it. So today we're going to break down exactly what IRBs and compliance teams need to know to make these difficult calls. And this is not just technical detail. As you're going to see, these decisions directly affect privacy, scientific validity, and regulatory responsibility. So let's start with the precise definition of what synthetic data actually is. Synthetic data is generated by computational models to statistically resemble real-world data. It is designed to replicate patterns observed in real people, patients, and populations. It's not random and it's not imaginary. Its value depends on how closely it mirrors real human data. So understanding how synthetic data behaves requires understanding how it's created. Synthetic data is created or generated using statistical methods and machine learning models, AI, trained on real human data sets. So it's often used to supplement or simulate or stress test models when access to real data is limited. Federal agencies, including the FDA, have recognized that synthetic data can be a legitimate scientific tool for early feasibility testing and model development. However, there are significant limitations on its reliability, representativeness, and regulatory acceptability for later stage validation or clinical decision making. So IRBs, you really need to know what stage the AI development is in when people are claiming to use synthetic data. The key takeaway is basically calling synthetic data fake is problematic because it obscures real risk and real responsibilities. And those risks start with how data is learned in the first place. So as this model shows, synthetic data generators, the tools that create synthetic data, have to learn from real identifiable human data in order to produce meaningful patterns of real humans. And that training data is usually identifiable. Sometimes it's coded, but otherwise it's sensitive information. So in practice, this means real human data, real identifiable human data is accessed, used, or obtained for purposes that oftentimes include research, product development, or commercial use. Models are trained on those real identifiable human data sets, and it's only afterward do they generate the new synthetic records. Now, this is where that misconception of fake data comes from. That outputs are new, But as our critical takeaway states, the model has to see and process and analyze real identifiable human data in order to learn those patterns in the first place. Now, this training phase involves identifiable private information, and that starts triggering privacy concerns. And so that dependence raises a fundamental regulatory question: when is any of this human subject research? So, under the common rule 45 CFR 46, research involves a human subject if the investigator does either um, one of two things. First, do they interact or intervene with a living individual for research purposes? Or two, do they obtain, use, analyze, or generate identifiable information for research purposes? So, whether synthetic data generation becomes human subjects research is going to depend on the critical question. And does that research team have access to the original identifiable data used to train the model? If yes, then you'll have human subjects. And the trigger is not the output, right? It's not the output of the synthetic data. It was the input of the real people. So we cannot just automatically determine something is synthetic or fake or de-identified just because they said it's synthetic data. The ambiguity is where privacy and re-identification risk have to be examined. That is the IRB's role, and that's exactly what we're going to explore next. So here's what we call the privacy paradox. Can synthetic data leak secrets? Yes, it can, and that's done through what's called model memorization. Sometimes AI models memorize the real people that they studied instead of just learning general patterns. This is a known phenomenon. There are two main types of privacy attacks that we worry about. The first one is membership inference. It's a big word, but basically when an attacker can figure out if a specific person, let's say a neighbor, was in a sensitive data set, for example, immigration or HIV registry, simply by querying that synthetic data. And then second is re-identification, where someone combines synthetic data with public information like voter rolls or whatever, which then allows them to unmask the real person behind the synthetic record. So re-identification is a real thing that happens with synthetic data. Which again triggers, is this actually de-identified or not? These risks are especially acute with small, rare, or high dimensional data sets. So even when the final data set is synthetic, then the research activity itself relies on human data in ways that warrant some kind of ethical review. So the IRBs will need to know about that activity. Was that activity of synthetic data generation covered by an IRB? And this is why focusing only on just like a final data set is really setting us up for missing important compliance considerations. And that brings us to how IRBs should actually evaluate these projects and what questions to ask. IRBs have to prioritize substance over labels. In other words, really read the protocol, really understand what's going on. Don't just take the PI's word for it. Hopefully, this decision tree helps. First question we want to ask is the data origin. Was real human data used at any stage to train or parameterize the synthetic data generator? If no, may more than likely IRB review is not required, but read the protocol and then thoroughly document your rationale based on that. If yes, then you would move to the next question, which is to verify access and control. This is two-part. Who generated the synthetic data, right? If a third-party vendor, collaborator, or data holder created it, then you'll have to verify if consent and HIPAA authorizations, data use agreements, or public health exceptions exist. If those safeguards do exist, then it makes for an easier review. If they can't be confirmed, then it just gets a little bit more complicated because of the compliance risks. And then that second part, right? If the researcher or the research team generated themselves, then we definitely have concerns for re-identification. And then that second part of access, right? Did the researcher have access to identifiable private information when they were training and generating that synthetic data? Usually it's a yes. Very rarely is it a no, but just for sake of this example, if it was a no, then we would want to document how it was coded with no re-identification key accessible to the team that actually generated that data with real data in the first place. Again, very unlikely, but if so, just document it. Usually it's a yes, which means that we'll go further into our review and document that. And then reach out to the final question, which is if consent was obtained or not. Did the researcher or the research team have consent for this specific use? Obviously, if no, or if they're just not able to confirm it, then obviously the IRB is going to dig a little bit more deeply into that. We have to worry about HIPAA and we have to worry about potential auditing risks. And finally, has the synthetic output been evaluated for re-identification or memorization risk? If no, then ask about it. The IRB should be looking into that. Again, HIPAA is a big one that it kind of gets triggered right there. And then if yes, then good, right? Want to document that the risks were adequately mitigated. And then ultimately, after you've kind of asked all those questions, you would make your final determination. Some possible outcomes might be not human subject research if no identifiable data was accessed in the generation of synthetic data. Sometimes it could be exempt so long as 21 CFR is not applicable. But usually it's going to be IRB oversight under 45 CFR 46. And if we're using synthetic data for the creation of tools that constitute a medical device, then 21 CFR 56. So these questions align with existing regulatory frameworks, and they're going to support defensible determinations. Beyond the common rule, synthetic data also intersects with FDA oversight and HIPAA requirements, as you can see in this decision tree. So lots to think about. Just make sure you document all of this when you make your determinations. As I was talking about the FDA, right? So beyond these privacy concerns like HIPAA, we've got FDA concerns and patient safety concerns as well. While IRB focuses on people in the data, for example, protecting privacy and individual safety, the FDA is focusing on that, but more on the impact of the tool built with that data. So it's a little bit of a different lens. FDA regulates AI enamel tools intended for medical purposes, diagnosis, treatment decisions, prognosis prediction, all that, for what they call a medical device under 21 CFR. And here's why synthetic data does not escape FDA scrutiny. It's if a medical AI is trained on synthetic data, then that synthetic data becomes part of the total product life cycle. So the FDA is going to scrutinize it as part of the evidence supporting the tool's safety and effectiveness or its design history file. In other words, synthetic data, it does not eliminate regulatory oversight because it's a part of the regulatory oversight in that design history file. That means researchers and developers need to demonstrate that synthetic data training adequately represents real clinical populations that it's intended to be used on and does not introduce bias that could harm the patients. And the quality of that evidence and ultimately the patient safety is going to depend directly on the quality and representativeness of that synthetic data, which brings us to our final consideration, those data quality standards. That I like to call this reality gap, this disconnect between synthetic data and actual clinic populations. Why does the FDA scrutinize synthetic data so carefully, and why should the IRB? The reason why is because of its fit for use. The fundamental question is like, that fit for use. The data has to be good enough for the specific medical question being asked. But here's the problem. First, bias. If the real training data had, like, for example, just a few minorities, then the synthetic data is going to ignore them. That's not a bug, that's a feature of how these models work. That's how they work. They reproduce the patterns that they learn so that they can be generalizable. But the result is that these medical tools are going to be biased against the very populations that they are supposed to be protecting. That second risk is hallucination. Most people are aware of this. The model might invent things like diagnoses that don't exist, or emergency department visits that never happened, or medical correlations that don't exist in reality. For example, a synthetic data set could suggest a drug side effect that doesn't exist or create spurious correlations between symptoms and diagnoses. These aren't just theoretical concerns, they directly impact patient safety, and we see them happening today. And this is why the FDA expects sponsors to prove the credibility of the synthetic data that they use. They have to demonstrate through rigorous validation that the synthetic data adequately represents real clinical populations and doesn't introduce these systematic errors. FDA guidance emphasizes transparency, validation, and documentation of all data sources, and that includes synthetic data. Synthetic data does that mean, right? So it means that synthetic data is not going to exempt you from FDA oversight or IRB oversight when you're creating medical devices or tools that constitute a medical device. In fact, using synthetic data could actually result in more scrutiny because of this reality gap risk. So let's look at how this plays out in practice with a real world example. So researchers want to build an AI tool to predict sepsis earlier, and they use synthetic records to train it. And so here's how this flows through both regulatory domains. First, the training, right? Real sepsis patients are in a hospital bed. Their data is used to create synthetic training records. The IRB question at this stage is, did the patients consent to use their data to train AI? Even though the output will be synthetic, the input is their very real identifiable human data. And so this is going to trigger HIPAA, more importantly, but it's also going to, as a result, trigger IRB review under 45 CFR 46. And then next is the testing phase. So now we have a synthetic data generator. The model is being developed for clinical use to predict sepsis in real patients. So the FDA question starts to come in. Does the data accurately reflect real sepsis progression? The FDA reviews whether this tool will be safe. Well, the IRB and the FDA would review whether this tool is going to be safe and effective as a medical device. And so those are things that you would look for under 21 CFR 56 and 50 and 812. And then next is clinical deployment. So you're going to use it in a clinical environment. And that could be for research, right? But a doctor is basically using this AI tool to make decisions about real patients. And so the real critical patient safety concern is if the AI learns from bad synthetic data, it might miss real sepsis cases in the hospital. And that is not a theoretical risk. It happens. A patient dying because the training data was not representative enough. It was too fake, or it didn't reflect the right population. So this example shows why both reviews matter, both IRB and FDA. Even though the data set is synthetic, IRB review is required because the use of the underlying human data and general human protections in the FDA 21 CFR 56 applies because of the model's intended purpose. So the regulatory obligations follow risk and intent, not just whatever the PI said that it was, in this case, synthetic data. So this example highlights several persistent myths that we should actually address directly. The most common three myths, starting with the first myth that synthetic data is not a risk to human subjects, is patently false. The reality is the generation of synthetic data often requires processing sensitive, fully identifiable information first. And if it's not done under the right oversight, then that means that that data will not be protected or handled safely. So we need to know who created these synthetic data sets, how and why. If it was done at a covered entity, then the generation of that data has to comply with HIPAA, and that means that they had to acquire it and process it under healthcare operations, which seems highly unlikely in this case. Or they would have to have done it under the oversight of the IRB, which means that there has to be an IRB protocol that covered that. And so you would be in the right to ask for that protocol number and protocol. So the other myth is that synthetic data is de-identified. Again, right? Reality is that in these days, nothing is de-identified. And in this case, we know that it is very likely to be re-identifiable. And reverse engineering can easily re-identify someone. But another thing is that the risk goes up when clinician researchers try to do these complex tasks of synthetic generation themselves. It is quite difficult, and so it should be done correctly. And if not, that's going to heighten that risk of re-identification and breach. And then, last but not least, is that AI research never involves human subjects, and so FDA and IRB is not involved. Obviously, as we've seen, FDA reviews the credibility of any data, whether that be real or synthetic. And they also realize that synthetic data is not going to be reliable for testing safety and effectiveness in the real world. So, it's best to avoid using synthetic data sets as a loophole for FDA submissions or hoping that you don't have to go through the IRB. The takeaway is that none of these claims are, these myths are universally true, and relying on them can actually lead to more problems down the line. So, what should research teams do instead? Uh, Here's a practical checklist for research administrators reviewing synthetic data projects. Researchers can refer to it as well. These four questions are going to help you make consistent and defensible decisions. First, provenance. Where did the original training data come from? It's best not to accept vague answers like publicly available data or de-identified records. You need to document which data set, which patients, what consent was obtained. That is going to be your foundation. The next one is validation. How was the synthetic data compared to real data to prove that it's accurate or actually representative of them? Ask for the validation metrics, ask for statistical comparisons. The burden is on the researcher to demonstrate that synthetic data adequately represents the real population that is supported by 45 CFR 46.111. And the third one, privacy check. So, was a distance test performed to ensure synthetic records are not identical to real patients? What is that? So, this is a technical measure. Essentially, it's how close is each synthetic record to its nearest real record. So, if the distance is too small, that means that you have a re-identification risk. So you're going to need to document all of this in order to understand that re-identification risk. And the last one is transparency. Is the use of synthetic data clearly documented in the protocol? This is not optional. If a project uses synthetic data, that fact, along with how it was generated and why, must be explicitly stated for that 45 CFR 46.111, supporting scientific integrity and regulatory compliance. And now some practical tips for applying the checklist. Just some red flags to look out for. Some common things that you might get told are, oh, well, the vendor told us it's de-identified, or it's synthetic, so privacy isn't a concern, or oh, we don't have access to the documentation. So that's not going to be sufficient. It's not going to serve your documentation requirements. And it completely ignores the training data origins. It's essentially unacceptable. If researchers cannot answer these four questions satisfactorily, then that's a signal that we need to hop on a phone call and figure out what's going on with that synthetic data. Scientific integrity relies on transparency, and that means you have to ask about these things, which brings me to the core message of this talk. Bringing it all together is the intended use drives determination. So think of it as this balancing scale. On one side, you've got data utility. And then on the other side, you've got privacy risk. The question isn't, is it synthetic or real or fake? The question we have to be asking is, what are we using this synthetic data for and what's at stake? We need a risk-based approach to oversight. So let's take two examples from opposite ends of the spectrum, right? So a low-risk study versus a high-risk study. A low-risk study might look like synthetic data used for software testing. Essentially, we're testing, does the button work? Or does the interface load properly? The clinical stakes are minimal. That's where it ends, right? And privacy risk is low. So oversight can be pretty proportionate to that low risk. Now, a high stakes example would be when synthetic data is used as clinical evidence. In other words, they're trying to test if the device could work or if it actually predicts sepsis or diabetes risk or breast cancer risk. Will this diagnostic tool save lives or harm patients? The clinical stakes here could be a matter of life and death. Even if the data is synthetic, the consequences of getting it wrong are severe. This demands rigorous oversight. Remember that checklist earlier, right? The four questions: provenance, validation, privacy, and transparency. Those questions apply regardless of whether the use is low risk or high risk, but the depth of scrutiny and the consequences of inadequate answers are going to scale with that risk level. So here's what this means in practice. Synthetic data is not, it's a tool, all right? It's a product, it's a tool, it's not a loophole. The label synthetic is not going to automatically exempt you from oversight. Um, the risk, you have to think about what could go wrong if the data is flawed. We have to think about identifiability. Can individuals be re-identified from the training data? And the intent, right? That intended use. Is this for clinical decision making? And so labels alone are not going to be enough to make oversight determinations. What I mean by that is just whatever the PI says is not enough. We actually have to have all of this documented, look at the context of the study, look at the substance. Um, Proportionate oversight doesn't mean no oversight for low risk uses. It just means that the level of documentation, the review depth, and ongoing monitoring should match the potential for harm, but we're going to have to understand that harm by asking more questions. So for example, software testing, right? That's less risk than something that requires clinical evidence. Um, And then, so what does this look like moving forward? This visual here says it all. Research and compliance. We're sitting at the same table, working from the same information towards the same goal. We're all in this together. That's what we need. So I have two specific calls of action for you. The first one is sit down and have a conversation with your researcher. If you're a researcher, sit down and have a conversation with the IRB and compliance teams very early on in the process. And that means before generating the data, before generating synthetic data, not after you've done it, not after you've built the model, and certainly not when you're ready to publish. Have these conversations at the planning stage when you can still make design choices that can even potentially streamline your project, but also make sure that it doesn't negatively impact oversight requirements. This early consultation is going to prevent a lot of problems, save you a lot of time and money. It's not going to slow down your research. It's actually going to accelerate it by avoiding so many costly issues later. And then second, document your intended use early and clearly. Put it in your protocol. Be explicit because that intended use is going to have a big impact on everything you do later. The level of oversight, the level of documentation required, and your regulatory pathway. So don't leave it ambiguous. Ambiguity is going to create lots of problems later. And here's why this matters. Our shared goal, and what I mean by that is by researchers, IRB administrators, compliance officers, all of us. Our shared goal is to protect the people. And that means privacy for the individuals whose data trains these models, and it means the safety for the patients and the people who will be affected by the tools built with this synthetic data. And it's not just about protection, it's also about enabling the innovation that synthetic data offers when done right. Synthetic data will accelerate research, enable collaboration, and overcome data scarcity challenges that have held back important work in the past. Synthetic data has the power to enable progress, but only when it's used with clarity, transparency, and appropriate oversight. Uh, so it's not a shortcut, it's not a loophole, but it is a tool in service of responsible innovation. And that's the future I'm inviting you to help build so we can move forward together. If you take nothing else from this talk, take this. The next time someone tells you it's just synthetic data, ask the four questions. Where did the training data come from? How was it validated? Was privacy tested? And is the intended use documented? Those four questions, provenance, validation, privacy, transparency, are going to serve you very well. You now have the tools to navigate synthetic data with confidence. Use them, and when in doubt, remember substance over labels, risk over rhetoric, and transparency overall. Thank you, and please reach out if you have any questions. And last, do feel free to take a screenshot of this checklist if you want a little bit of extra support when you're reviewing your studies. And with that, we will end the webinar.